All right, good morning, everybody. Glad you could join us this morning. It's a little dark out, but hopefully the sun will come out tomorrow. It is my pleasure to introduce Dr. Markus Meyer. He is the Engdahl Family Chair in Heart Failure Research at the University of Minnesota. He specializes in the interplay between heart rate and cellular calcium cycling in heart failure with preserved ejection fraction, which, as I think most of us know, is incredibly common, can affect up to 1 in 5 people over their lifetime, and treatment for this problem has been a challenge. His research aims to develop an innovative pacing therapy that integrates personalized accelerated pacing and conduction system pacing, which I'll just add as an additional anecdote. Chronotropic incompetence, for example, and heart rate problems are one of the things that can lead to symptoms in heart failure with preserved ejection fraction. Dr. Meyer is employing a bench-to-bedside approach and investigating molecular mechanisms, experimental models, and studies human heart tissue while pioneering clinical trials. Early results indicate this novel treatment may effectively reduce the burden of HFpEF and atrial fibrillation, which we learned about last week, so I don't need to remind you that that's a common rhythm disorder. So welcome, Markus.
Peter. Thank you for this kind introduction. Peter and I sometimes rarely meet because we have actually a Twin City HFpEF club, and we meet every second Monday every month. It's like all the institutions and talk HFpEF a little bit. So if you're interested, my email is going to show up on the last slide. Send me an email. Happy to include you. I'm going to talk about pacing for new populations. I'm German originally, and then went from California to Vermont. And when I saw this opportunity and had started to work with Medtronic, I knew that I have to be closer to them to push them to get this over the finish line. My disclosures, the main one, actually, I have patents in this area that Medtronic is licensing. So you have to take everything with a grain of salt because I'm heavily biased. Before you go into pacing of HFpEF, there's no way around not to talk about beta blockers, because many of the things we do, we tend to reach to beta blockers. In fact, we are overprescribing them by quite a bit. Currently, about 10% of the adult population is on a beta blocker. 10 years ago, that was 11%. So what is true about beta blockers? We know that they are beneficial in HFrEF, but only a minority of cardiologists actually know that as soon as you have atrial fibrillation in HFrEF, that they are not reducing mortality and they don't reduce hospitalizations for heart failure. And the guidelines now acknowledge this. This is based on randomized data, so we're very certain about this. We know that beta blockers lower blood pressure, but they're inferior to other blood pressure medications. Actually, if you look at the evidence we have on historic beta blocker comparative effectiveness trials, we know that patients on beta blockers are about 30% more likely to develop atrial fibrillation when they have a hypertension. We know that beta blockers reduce angina, but that does not translate in a mortality benefit, has never been shown. We feel good about it and think it should, but there's no data to support that. In fact, when they looked at ivabradine, another way to reduce blood pressure, what they found is that there was no improvement in patients with coronary disease, except there were 2 signals. One was a very significant increase in atrial fibrillation, so pushing down heart rate by 10 beats per minute increased the risk for atrial fibrillation, and it increased the risk for heart failure hospitalization. Rate control in atrial fibrillation, we have new guidelines, class 1 recommendation, purely expert opinion. There is no randomized trial that suggested that beta blockers are superior to other rate control medications. In fact, when you look at the smaller randomized evidence, there are good suggestions that even digoxin is better than bisoprolol, as shown in the RADIAF trial a couple of years back, published in JAMA. I tend to lean on diltiazem for rate control if I really have issues. And the truth is, often in HFpEF patients, when they're elderly, we don't really need much rate control anymore. And then there is this old saying that we all have heard on rounds, and I even taught that if you prolong ventricular filling, that this should be good for patients with heart failure with preserved ejection. But in fact, when you look back at the first hemodynamic studies of propranolol, you will see that propranolol was reliably increasing filling pressures. And heart failure is all about filling pressures. So again, the evidence for beta blockers, we give it to 10% of the adult population, but it's really only the patient in HFrEF and sinus rhythm who derive a benefit, and that benefit is huge. So my practice is obviously giving patients with HFrEF and sinus rhythm beta blockers at high doses, but as soon as they step over an AF of 50, I usually pull back or even stop them. And that's a little bit against the guidelines, but the guidelines are only leaning on one trial out of England. And Joel, who worked with me, sort of knows how I sort of handle these patients. And he told me that one of his favorite things now is to de-prescribe beta blockers. Again, the contemporary evidence, you all heard about the ESC trials that didn't really show much benefit in heart failure preserved ejection fraction. There's a little bit of benefit in patients between EF 40 to 50%, but not otherwise. In all these other areas, really either signals of adverse responses or like neutral effect of beta blockers. Clearly, they are not good medications for hypertension, and we have much better medications that we should use in hypertension. The most overused area of beta blockers is still hypertension, probably followed by atrial fibrillation. So a couple of years back, we started to tell the world that actually pushing heart rates down is not a good thing. It's okay to have low heart rates when you're younger and got compliant myocardium, not much issue there, but even master athletes, they run the risk of developing atrial fibrillation due to their low heart rates, which again will raise filling pressures as they get older. So we propose that prolonging relaxation is in fact a bad thing because you can only prolong relaxation and increase the size of the LV if your pressures go up with the filling, and that will create more wall stress. Therefore, completely unsurprising that in the beta blocker hypertension trials, they found 20 years ago that BNP levels go up on beta blockers. So completely expected. So below normal heart rates will lead to higher filling pressures. They induce chronotropic incompetence. And these are sort of the symptoms we have in younger patients that are on high doses of beta blockers, leading to all these things. So if you're like older and you get a high dose of beta blocker, you're basically receiving a HFpEF in a pill. So we really need to move away from giving these high doses of beta blockers, specifically in the elderly. At age 80 or older, about 40% of the population is on a beta blocker. In fact, you can see this, you see this big, beautiful ankle there? Yeah. You may have seen this in the lay press. This is a guy who was diagnosed with chronic venous insufficiency. I would argue that actually he has heart failure with preserved ejection fraction, and he's running the risk of having atrial fibrillation. And his heart rate is actually below what would be expected to be normal, even for his height, which is 6'3". So let's just talk a little bit what are the principal drivers of HFpEF and atrial fibrillation. First of all, they come they are linked together because both conditions are really driven by the elevation in filling pressures. And as we age, this happens to all of us, unfortunately. At about mid-age, there is a adverse regression of LV size, which goes along with the thickening of the LV. That's well documented in population studies. And with that, filling pressures will come up slightly. So the LV regresses by about 1%. This is the volume, by about 1% per year. And because the left atrium has to overcome this increase in pressure, it gets actually bigger by 1% per year. So we all walk into this as we get older. However, this can be greatly accelerated if you have, in particular, hypertension. Hypertension these days is mostly driven by obesity. It's not a coincidence that obesity rates in the US are about 40% and hypertension rates are 40%. So reducing weight is a very effective way to treat hypertension, as we now see with the GLP-1 agonist trials. But there are like other factors that tend to help this. Inactivity is one, conduction delays on the EP side is one, and low heart rates, as I just told you, are like factors that really accelerate this. And then you have HFpEF or atrial fibrillation showing up in younger age groups. Typically does not happen in children, as we know. This is not entirely a new problem. This is a painting that's nearly 500 years old. Back then, food was like not as common, more sparse than it is now. And this painting is actually, this is in Munich, and the guy was in the Netherlands. But when I look at these two folks, they look like atrial fibrillation and HFpEF to me. So it was a condition of privilege, and because I feel that they're so connected, we actually move their hands together. So let's go to the dark side of heart rate, and a lot of people will tell you don't go there. So 10 years ago, when I had this idea, I knew that there would be a lot of pushback because the guidelines were still giving beta blockers a class 1 recommendation in heart failure preserved ejection fraction that then became a class 2 recommendation. So I had basically all the experts against me. Epi guys would say, oh, but don't we know that high heart rates are associated with death? That's true, but they are also associated with death because we get sicker. So also not a concern. The basic guys would say, oh, this leads to calcium overload, and then you have delayed after potentials, which could induce more malignant arrhythmias, and you may die. So don't go there. But I decided to go there anyways. However, this is complicated because, you know, if you go against experts, they basically have to die to allow that your new view will gain some ground. But I had actually a couple of good reasons to go there. I sort of realized that this Eric Topol paper from the 80s, where he said maybe there's a benefit of atenolol or beta blockers in this, was not true, because I saw at the time I had to retrain in the US, and it was in Vermont, and I saw a lot of elderly women coming in on 100 milligrams of atenolol in flash pulmonary edema at night, which we, by at least over at the U, we don't see these patients anymore. And that tells you something about beta blockers. I had my bench research, which told me there is an opportunity, and I had a patient experience. And I went to my mentors at the time, and Burton Sobel was sort of the most famous one. He was a TPA guy for MIs. And he said, you know, NIH is not going to fund this because you're like against everybody, so to speak, right now. Go to Medtronic. So I went to Medtronic, and they liked the idea because I told them, I said, you know, do you want to sell twice as many pacemakers? And that opened their ears somehow. So they kept on funding me. But then down the hall, I had this guy. His name is Dan Lasgard, and the EP folks may know him. And he is really a pioneer in conduction system pacing. So he sort of reinvented his bundle pacing and is still practicing that. But around 2005, he also engaged himself in Bachmann's bundle pacing. Bachmann's bundle is the natural connection between the sinus node over to the left atrium. And it provides you like a fast pathway to get the left atrium engaged and activated. And so the basic theme or rationale of this approach is that you use safe pacemaker systems that provide a normal activation sequence, meaning conduction system pacing, and which also means that with a normal activation sequence, you will have a normal relaxation sequence. So it's a very effective way to reduce filling pressures, and then you expose patients to accelerated pacing. But before we go there, let's talk a little bit about the substrate that we are dealing with. So what's happening in the myocardium? And for me, the main reason to go to Vermont is that they started in the 80s to collect LV epicardial tissues of patients who underwent bypass surgery. And the surgeons were very comfortable with this. The patients were very comfortable. The IRB was very comfortable with it, and they're like, this is a great base to get to myocardium of patients. And what we found in these patients is not unexpected. You all know this, that there's more fibrosis. Fibrosis is collagen-based. However, there are like other things happening. Like there's a big structural protein that's part of the sarcomere that's called titin, and that tended to be hypophosphorylation. So it was not, when it's phosphorylated, it gets less stiff and therefore more compliant. Being hypophosphorylated makes it stiffer. So two basic mechanisms that we published in Circulation some time ago. When you go, the heart failure folks of you who may go to the Heart Failure Society of America meeting, they will hear a lot of inflammation. Having these tissues gave me an opportunity to look at the inflammation. There ain't no inflammation in the myocardium. Yes, there's systemic inflammation. IL-6 levels are higher. There are ongoing studies about this, but the myocardium is not inflamed. Inflamed myocardium is called myocarditis and not HFpEF. Yeah. So we really don't see that. There's a small trend towards having more immune cells. We even looked at pathways. They're very sophisticated methods where you can look at the expression of all the genes in the myocardium, and the pathway analysis does not give you that there is more inflammation in these tissues. The controls are really good, and they are harvested exactly the same way. So this is fairly reliable data, actually also confirmed by two other groups. As Peter told you, I'm a calcium handling guy, and I like calcium because it really runs the ship when it comes to contraction and relaxation. And from these biopsies, we were able to craft little strip preparations and run like pacing protocols on these strips that are stretched to develop maximum force. And we found that the prolongation of relaxation is really a calcium-mediated effect. It's present in isolated myocardium, and all the numbers we find in the cath lab, like a prolongation of tau, is already there at tissue level. And as you can see, when we did a little force frequency ramp here, we see with the force, diastolic calcium levels come up. And for a couple of years, I was translating this wrong. And I was like, so force translates to pressure. So if I go faster, pressure should go up. But that actually doesn't happen in vivo because this is an extreme situation. What happens in vivo is the following. When we pace the heart faster, we have an increase in calcium levels, and that leads to a reduction in LV size. And this is from a pacing study I did with Dan Lustgarten in the EP lab, patients in sinus rhythm just on their way to undergo PVI. And that reduction in LV volume is really calcium. And the opportunity I then saw is if you can reduce LV volumes, not many of you will think in pressure volume loops, but one of the best descriptions of the hemodynamic properties of HFpEF is a disproportionately steep left ventricular end diastolic pressure volume relationship compared to a normal control. So if you can nudge the end diastole to a smaller volume, you should actually, in fact, end up with lower filling pressures. And it's a very effective way to normalize filling pressures. And basically, the sequence is you abbreviate diastole, there's more diastolic calcium, less passive stiffness that you have to deal with, and therefore lower filling pressures. There was historic data in a case series of 60 patients that showed when you go to an atrial pacing rate of 120 that you can completely normalize filling pressures. From 17 to 9 in our experience, but very similar to that previous report that was published in Circulation. A medication like SGLT2 inhibitors gets you maybe 2 millimeters of mercury. So that's a huge difference compared to what we can do with medications. Diuretics, yes, they can be slightly more effective, but they won't give you something like this. And again, in this pacing study, we actually collected blood from the coronary sinus, and when we stopped the pacing, we could show that in patients with HFpEF, there was like an influx of calcium. So the hearts of these patients tend to hold on to more calcium. However, in mammals, when you pace them above normal heart rates, you will induce eccentric remodeling. We see this clinically as tachycardia-induced cardiomyopathy, but there are like many in-betweens there. And one in-between would be like a pregnancy, where you have a physiologic enlargement of the LV, and the heart rate plays a role in this. So I proposed to Medtronic to do a pig micro-swine study. It's a hypertension model, so what precedes HFpEF, these pigs don't have HFpEF, but they have hypertension. And I said, their resting heart rate is typically 90 beats per minute, around 90 beats per minute. Let's go to 150 and see what happens. And we went to 150, and within 2 weeks, their LV volume had basically almost doubled. And then I called them up, and the original plan was to go higher, and said, we don't need to go higher. We need to go lower. So I reset. These were like 4 initial picks. The data here is actually for many more picks. I said, let's go to 125. And lo and behold, 2 weeks later, the LV had regressed to somewhere between normal and 150. And then I sort of started to dance in the lab, because I knew I could use heart rate as a plasticity modulator that is more akin to athletic remodeling, not pathology, where you can increase LV volume. You actually reduce LV thickness, because this process is mass neutral, but you will reduce ejection fraction. In a way, you can use heart rates at a dose, and you can rate shape your LV. So you could do this with a pacemaker. You can then say, hey, I stop at a heart rate of, let's say, 80, and then I push it further. And now the person is in the hospital. Yeah, that would be tachycardia-induced cardiomyopathy, so I don't want to go there. By the way, in children, they would not be affected by this. There are some small children going at 250 for days, and they may be a little bit unhappy, but that's pretty much all they show, which tells you a little bit something about heart rate too. So what are normal resting heart rates? We know with blood pressures, they seem to be, we tend to tell patients 120/80 is normal, but with heart rates, it seems to be a little bit different. The range is wider. And we know that 95% of the population is living between 60 and 100 beats per minute. Most cardiologists, they would say a normal heart rate is like 72. But when you look at the population data, it's actually 80. So it tends to be a little bit higher than what we think a normal heart rate is. And in fact, we all reproduce a spectrum of heart rates as we grow. In mammals, mice tend to go between 600 and 700 resting heart rates. Blue whales, 10 beats per minute. When they dive, as low as 2 beats per minute, because they have hearts of the size of a car. So unsurprising. In humans, we start off at 130. Then as we get older, the heart rates drop. So there seems to be a body size heart rate relationship. And then after mid-age, although we are not growing anymore and often shrink a little bit, the heart rate trends lower and lower and lower. Okay, could we do something with this to give patients a more normal heart rate? And when you look at the population data, this is US population data, you will notice that there is actually a fairly good linear relationship between height. These are children at ages 5 and 10, and their resting heart rate. In fact, it pretty much explains the difference in heart rates between women, where it's a little bit higher, and men. If you end up to be a Witherspoon, your heart rate is closer to 80. That's perfectly fine. If you end up to be a Michael Jordan, it's around 60 beats per minute. So we really have to move away of using population data to justify a pacemaker setting of 60 beats per minute. By the way, Earl Bacon, they justified this at the time because they thought a human had only a certain number of heartbeats. And they said, we don't want to use it up too fast. That was sort of the argument. So we are not doing this elderly, unhappy female who has a small heart a favor by leaving her pacemaker at 60 beats per minute. That's not a normal heart rate for her. What the population data really means is that only 2.5% of adults have a heart rate of 60 or less. That's what the population data means. So what are normal heart rates in the HFpEF populations? And they are a good one to always look at other trials because we really have high quality data on it. And when you look at the HFpEF outcomes trials, there are like a couple of them, they're all clearly below 80 beats per minute, which would be the population average. But they are even below the healthy adult population, which in fact would be 72 beats per minute. And when you look at the trials and look at the baseline characteristics, you will notice that many of these patients are on beta blockers. They are not typically on high doses. And even taking a little bit of that beta blocker away, because most of these patients don't need them, will help them to feel a little bit better. It would be very hard to do outcomes trials on this, again, because the doses that we commonly use in this population are not very high. But it may give some patients a little bit more room to breathe. So after thinking very deep about this for, again, a year or so, I came up with the myPACE algorithm where I said I knew that if I pace patients too fast, I would reduce their ejection fraction. And then the heart failure guys would say, oh, I always knew that this was a crazy idea. Don't want to go there. So I decided that I would give a patient with an AF of 50 just what's considered to be a normal resting heart rate, which is in fact for the average heart rate a little bit smaller because most of us are dippers, meaning our heart rates at night are actually a little bit lower. So somebody with an AF of 50% would just get a normal heart rate given with the best possible conduction system pacing, which is safe, should reduce filling pressures. And in everybody with an AF of above 50%, they would get incrementally more heart rate. This was a wild guess on my side. I just wanted to have the modeling done in a way that in the below normal AF range, that it would land in the zones where we know we have efficacy from the beta block outcomes trials in HFpEF. So it was modeled this way. In somebody who's very short and lives and is most often female, they may be paced at almost 90 beats per minute. So quite a bit different from what we are doing currently. What happened over the last 2 years is that the EP world got really excited about Bachmann's bundle pacing because if the principles of LV physiologic pacing apply to the atrium, Bachmann's bundle is the most natural target. Anatomists would have argued this is not a conduction system. I disagree. Together with visible heart, we actually looked at biopsies of normal patients. And when they looked at conduction systems, which is now like almost 150 years ago, they didn't really have the dyes to have connective tissue show compellingly. But when you look, this is a folded example of this goes from the right atrium, and this goes into the SVC. So it's that cut line in B is in the area where the Bachmann's bundle is. There is actually connective tissue. So these fibers are shielded from the working myocardium of the right atrium by connective tissue, which gives you a fast connection between the sinus node. Then the fibers go around the SVC. They reconnect in the Bachmann's bundle, which is quite a thick structure. And it's just at the junction where the SVC dives into the RV towards the septum. And it's the fast pathway to get to the left atrium. And we have come to recognize that in particular at heart rates, when we did the pacing studies, I saw these V waves at high rates. And I thought these were V waves when we looked in the left atrium at the pressure waves, but they were not. It was basically the lateral portion of the left atrium coming in late when the mitral valve is already closed. So by putting the lead in the Bachmann's bundle, you can sort of overcome this limitation. On average, you can reduce your P waves by about 35 milliseconds. The longer the P wave is at baseline, the more benefit you will have from Bachmann's bundle pacing. So this is really taking off. And then before I left Vermont, I set up this trial that Medtronic didn't want to pay for. Then they regretted that. But I felt it was important to look at patients with HFpEF with pre-existing pacemakers. And again, most of them we knew were set at 60 beats per minute because 80% of the patients in the whole country are left at 60 beats per minute. And we randomized to either leave them at 60 beats per minute or give them the myPACE rate. We followed them for a year. We needed about 100 patients, so we were a little loosey-goosey in whom we included, so even patients who didn't carry a diagnosis of HFpEF. And we looked at quality of life or health status assessed in the Minnesota Heart Failure Score. Secondaries were NT-proBNP, physical activity hours, atrial fibrillation burden, and lo and behold, we found a very large improvement in health status and quality of life that was accompanied by beneficial changes on NT-proBNP. What I didn't quite expect is that people became more active. HFpEF patients at baseline have about 2.5 hours of physical activity where the pacemaker would be triggered to collect that data. And they went up like 35% in their physical activity. With the exception of GLP-1s, I don't think any medication can do that. And as expected, we found a reduction in atrial fibrillation burden that was significant, and the relative risk was reduced 28%. It was mostly, though, the micro episodes of the atrial fib that were like suppressed with this. But we know very well that they are precursors to longer episodes. I tend to get like these notes. This is a lady from New Zealand who thinks that my algorithm saved her life, which is probably not true. But she's now on her way to reform the New Zealand medical system to let them know that 60 is not really a good heart rate for everybody. We have follow-up data. We could show, these were blinded echo reads, that the septum got a little bit thinner by 10% over the course of 3.5 years. There was a trend towards bigger LV volumes, mostly systolic volumes and mass to volume ratios. And there was a trend on LA volumes. And in all 3 reads that we did from independent echo readers, we saw that ejection fraction was reduced. But nobody dove below 50. So that should alleviate concerns from the heart failure folks. We just published clinical outcomes data. Again, this is now not randomized anymore. This is strictly observational. And there's no perfect way to analyze this because crossovers started after the trial. After the trial, we told the patients, we can leave you where you are, or we can cross you back to 60 beats per minute. The majority of the crossing back patients at 60, they called within a week and said, oh, I want to beat fast again. So that was like an encouraging sign. And when we collected outcomes, this is a composite of death, heart failure events, atrial fibrillation events, strokes, and myocardial infarctions. We had quite a bit fewer events in the faster rates, suggesting that the data is clinically leaning the right way. This is no proof. This is secondary analysis. There was complete unblinding, especially after we knew the results, as you can imagine. So this separation is sort of eaten up here because we had so many crossovers in the intention to treat analysis. When I came here, I wanted to have an independent confirmation that this is really true and done by heart rate. So I did a Cilostazol N of 1 trial in 25 patients where we had a medication box set up. And 1 week they were like on placebo, then Cilostazol, placebo, Cilostazol, everything within 1 month. Cilostazol is a peripheral artery disease medication that reliably increases heart rate by increasing CAMP levels in the sinus node. And we looked at health status, this time assessed with the smaller KCCQ. Also NT-proBNP levels in 5 patients had cardiomems. So we actually saw their recordings. And Cilostazol reaches a peak blood levels within about 4 hours, so it is fast onset. And there are some patients who basically at the end of this, they knew exactly when they were taking the Cilostazol. And they are my super responders. And every time somebody stops it, they call me, I want to be back on it again. Keep in mind, it has a precautionary black box warning that was put on it in '99 because of the well-known outcomes trials for heart failure, but HFpEF didn't really exist or was not understood as an entity. And I've never run into problems that like a pharmacist calls me up and said, I cannot give this in a heart failure patient. So I give this actually quite a bit, and I probably have a cohort of like 20, 30 patients who take Cilostazol. Other populations to benefit, clearly the one that's the most substantial and should derive the highest benefit is patients with non-obstructive hypertrophic cardiomyopathy. And because when you go to meetings, you hear this hypercontractility thing. But the basic reason they are hypercontractile is because these mutations are calcium sensitizing. So for the same level of intracellular calcium, you get more contraction. We did a small case series that was published in JACC last year, obviously unblinded, just 6, 7 patients, but we saw directionally this sort of similar results. In these ones, actually, even with an improvement in VO2 max, but again, unblinded. Cardiac amyloidosis is another opportunity, and I'm working with, what's his name, Matt Meyer from Columbia, who is like a world expert in this, to see if we can get this to an IH level. And we are just preparing for like a case series of 10 patients where we use accelerated dual rate pacing to keep like remodeling mechanisms alive in the hope that it could kick out the amyloid. That's maybe a little bit far-fetched, but why not try? We have our first patient is doing quite well. He unfortunately has so much neuropathy from the amyloid now that he cannot walk anymore, but hemodynamically very stable. And the biggest opportunity by far is obviously atrial fibrillation, because with accelerated pacing, you can elevate the rate floor, which again helps you to lower atrial pressures, and as a tool that may reduce could be useful for primary prevention and secondary prevention. We all know that AFib and HFpEF are closely linked. We have all seen these papers where as soon as you have atrial fibrillation, it becomes much more likely to be diagnosed with heart failure, most often preserved ejection fraction, but also vice versa. You're diagnosed with HFpEF, you're still in sinus rhythm, you're much more likely to develop atrial fibrillation. In fact, in the outcomes trials, about half of the patients in the outcomes trials also have atrial fibrillation. For me, like a really wake-up call from the heart failure side was I always went to these EP meetings and they were talking about irregulopathy, that the heart doesn't like to be irregular, like things can happen then, they are much more likely to get a heart failure. And it was this rather small but multi-center, well-conducted European trial where they compared PACE and ablate versus medications. And tell me any drug trial that has a number needed to treat of 4. That's a monster benefit that even included mortality. So when they just looked at mortality, they could see that PACE and ablate, which sounds awful, you're killing the AV node, it's horrible. These patients tend to do better. And when I talk to the guys in England who did the reanalysis of the beta blocker outcomes trials, and I asked them, why do you think AFib is bad? They were all talking about the pauses. And obviously, PACE and ablate makes these pauses go away, but accelerated pacing could make these pauses go away too. And in fact, with my colleagues in Vermont, we just published, they are accruing now more than this one patient where in select patients where you do PACE and ablate. And by the way, the EPs will notice that about 10 to 20% patients who you do PACE and ablate, they will go back into sinus rhythm and then don't have an AV node. Yeah, so they need really two good leads. So Dan Lasgarten puts in really two good leads, obviously blind in the Bachmann's bundle because they are often in AFib, these patients. But he knows it so well now where the Bachmann's bundle is. And then he does like a his bundle lead typically or left bundle area lead. And in these patients, you can see after like 2 weeks, she went back from AFib into sinus rhythm. And she's still in sinus rhythm, being paced at her accelerated rate and loves it. So we are sort of looking at that in more detail. And we said, maybe sometimes you can hold off ablating the node, just go pace faster and have the leads in good spots. And that gives you the hemodynamics that should be beneficial and reduce the risk of future atrial fibrillation. Another opportunity is mitral and tricuspid regurgitation. I showed you how the heart gets smaller. If you know how AV valves work, they depend a lot on the size on the LV, so you can actually increase the coaptation. And I tried this in a couple of patients where I actually gave them Cilostazol, and then we did sort of an echo before and after, clinically justified echoes. And it looks better by echo, not that that necessarily means something, but that may be another opportunity. So pacemakers have gone a long way. They came really, they were developed in Europe, then Earl Bakken picked it up with the first portable battery-powered pacemaker, and it went from just merely backup pacing to continuous pacing. We know for certain it has a benefit in reduced ejection fraction patients with a left bundle. We know this for certain from the CRT outcomes trials. We believe there are like opportunities in the HFpEF world too, as I just told you. It's not just heart rate. Pacemakers are really doing so much more these days. They are hemodynamic boosters, they are rhythm managers, they are like a Fitbit in that they record all this data, and they are a plasticity regulator. When you integrate all of these things that pacemakers could do, the biggest benefit, I believe, that this will have is an improvement in symptoms that usually tracks along with improvement in outcomes, but we cannot be certain. And this is just showing the data on either QCCQ and Minnesota scores. They both go to about 100, so that you can calculate the relative benefit. And when you look at Paragon, no improvement in symptoms. This was Entresto. Emperor preserved was like 2-point improvement in KCCQ. Most patients will not fall around your neck if you start Jardiance or the Deliver drug, which is dapagliflozin. Deliver was large enough that they could see the benefit, but it was like an improvement of like 2 points on the KCCQ scale. Fine Arts was also large enough that it showed a significant benefit. The Summit trial, that's GLP-1, different story, but that's a select population of HFpEF patients, overweight, obese. Yes, there was a benefit, and this is the Cilostazol data. Where pacing seems to be superior is on symptoms. And the one thing you get with a pacemaker is adherence and better medical follow-up because they have to come in. So you get like secondary benefits. But of course, you have about a 10% risk of complications from a pacemaker implant. So they are unbeatable on adherence. We know from the diabetes GLP-1 outcomes trials that about half of the patients stop them after 2 years. So it's going to be a tough one to, it's helping my patients and I prescribe them, but it's clearly not, it's not going to be a miracle. This is where we stand. This was the Medtronic University of Vermont bubble for a while. We were just by ourselves. Now we have independent confirmation of our data from both Medtronic. They did a small study in China. This was new implants for Brady indications, and they just compared 60 to 75 and saw directionally the same benefits. There's an Indian study in patients with non-obstructive hypertrophic cardiomyopathy that had very similar results than myPACE, and that was completely independent. And then there was like our evidence, which was also outside of Medtronic, also out of my hand. I just helped them with the rate management. This was our small case series, but there are like 2 more studies currently enrolling. So in conclusion, HFpEF and atrial fibrillation have a shared myocardial substrate. We believe that personalized accelerated conduction system pacing has both disease and substrate modifying effects that could be useful in the prevention of and treatment of HFpEF and atrial fibrillation. We have a small trial with Medtronic right now, 50 patients, where we really feel out the upper limits of this. And we have like 1 patient who was calculated to run at 90 and 110. That was her randomization, and she called the team and said, I haven't felt as good in 15 years. I hope she's not in the placebo group. Because, because putting in an implant has a huge placebo effect. In fact, if you sell it well, you could implant an empty battery and patients would feel quite a bit better. So we have to be still very careful, but a large global outcomes trials has started to enroll, and I cannot say how far we are, but looking good. If you have questions, if you see HFpEF patients, I know most of us are like, no, I'd rather take that AFib patient or something. But if you see them and they have low heart rates despite reducing beta blocker trials, and you feel, or they have a lot of symptoms, and you feel they could be a candidate, just call me straight, send me an email. We are happy to get them into the trial. We can enroll like 50 patients locally. And I've already 20 of my own patients sort of lined up for this trial. So as you can imagine, you never do this alone. This was a large effort from multiple institutions, and I had a lot of help. And some of you will know John McMurray, and the first author on myPACE. She was giving a talk at European Heart. And John walked up to her and said, I have to say, I think I was wrong. Because he was like one of these reviewers who said, this is crazy, we cannot go higher. So we seem to be able to slowly convince the experts in heart failure that this is at least worth a try. So thank you very much for your attention.
Thank you, Markus. That was fantastic. One of the things that's appealing, too, is it's, in a sense, very simple, of that we need higher heart rates in these patients, and often the simple things are what works. One of the medications that came to mind to me as a transplant cardiologist, we often use terbutaline in the early period. Have you studied the effect of terbutaline, or might that be an alternative to Cilostazol?
As you can imagine, my transplant colleagues tell me the same thing. And they say, we see this often when they have edema after the transplant, and that's one of the reasons to use it. I personally have not used it because Cilostazol is so easy to use. And by how much does it increase the heart rate?
I don't know. I mean, we like to think it bumps it by 5 to 10 beats per minute, although I recall joking, I had a surgeon that I used to work with who liked using isopril.
Yeah.
And we would joke that we started the terbutaline, but he didn't like to stop the isopril. And we would start the terbutaline so that we could tell him, well, you don't need the isopril anymore. We've got terbutaline going. So we've sometimes wondered how effective it is, and that we use it as a placebo to manipulate our surgeon's behavior.
But it's certainly
we never do that.
Certainly a great idea, but I reached to Cilostazol because there's a lot of safety data. FDA mandated a lot of safety data, and I really did deep dives because I didn't want to endanger my patients, because I let them sort of go home and not being watched very closely. And I walked away from that data as I was confident that I would not harm them doing it. So that's why I use Cilostazol.
Sure. Yeah. Thank you. Any other questions? Yes.
Yeah. So in endurance athletes, cardiac output is, so that the heart rate is reduced and cardiac output is maintained by increasing stroke volume. And so in the patients you're treating, the way I understand it now is that what happens is that the heart rate is reduced by beta blockers or sinus node disease, but the stroke volume is not maintained. to maintain cardiac output.
With beta blockers, the stroke volume may go up, or probably often goes up. But what people forget is the rest of the equation. That's the number of heartbeats. So with the pacing, I'm reducing stroke volumes. I know this for certain, but I maintain cardiac output just because I have more beats per minute.
Okay.
And the athletes, I did a lot of athlete reading when I started to think about this. And pregnancy readings, actually. Women who are like athletes, if they go into pregnancy, they're often better after the pregnancy.
Oh, yeah.
And there was like, I don't know if I should even mention this. There was like in the 80s, there was like even, there was talk about abortion doping, where like some Eastern country athletes were seen pregnant, and then all of a sudden at the Olympics, they were not pregnant anymore. And in women, it's actually well described and even quantified that this is a real deal. And the LV sizes get bigger in pregnancy, and heart rate plays a role in this. Like Tour de France athletes, before the tour, they have EFs as low as 40, completely normal, because they have bovine hearts, they have enormous hearts. They can afford to have an EF of 40%. However, and that's fine when they're like 20s, 30s, 40s, but when they get older, the myocardium gets stiffer. That's why the EP guys see them as like vagal atrial fibrillation, because their low heart rates now increase their filling pressures, which sets them up for atrial fibrillation as one of the mechanisms that drive this. But it seems to be resembled, the pacing, what it does to the myocardium is probably has more to do with athletic remodeling, so within physiology, than inducing something pathologic, as long as you don't drop the ejection fraction too much. So it's like we're gaming physiology here.
That was worth getting up for. Thank you.
Totally.
Have you had a chance to study in the pig model what % of the time it's necessary to pace at a higher heart rate to achieve the remodeling? I mean, versus 100% versus 25% or what?
Yeah, that's a very good question, and this is unpublished. And initially, I thought I would just pace people at night. And we used Medtronic pacemakers, and they have a sleep function thing that's meant to lower heart rates. And we told the pacemaker, oh, this patient sleeps during the day, which allowed us to increase heart rates at night. And because I thought that would be the end of the story, because at midnight, all of a sudden, the pacemaker was ramping up to 100 beats per minute. And I wanted 3 digits because it's like, hey, you've made 3 digits. And these patients could tolerate it just fine. But you don't get the remodeling. So in pigs, when we pace them at 170 and we limit it to 12 hours, you don't get the remodeling. The pauses in between, or like the normal resting heart rate in between, seems to be enough to keep everything at sort of normal dimensions. That's why we knew we have to work on the rate floor. I knew Medtronic was not completely, did not buy in on that at that time. And so that's why we did the myPACE study. And I was scraping together money to do that. We did this basically unfunded, just from like leftover money I had here and there. But you have to pace continuously. Yeah.
I'm imaging cardiologist. Thank you so much about the lecture. So my specialty is about heart disease. In the field, the pacemaker-induced tricuspid regurgitation is a hot topic, so unmet need. So I was wondering, so what do you think about how we can put together? Well, what's the data about the pacemaker-induced?
I mean, there is leads can worsen tricuspid regurgitation. It's not very common though that you can really pin it down just to the lead, but it can happen. I think technology will, that conduction system pacing over the long run can be done without leads. I'm pretty certain. We are not there yet, but I know that companies are moving that way and trying to get it there. Medtronic has an approach that they're working on. Other companies have approaches. I don't think we will be lead dependent. Probably for the rest of my career, we will have to still deal with leads. But we have learned so much on conduction system pacing now, and all the data is following the hemodynamic data, meaning clinical outcomes data. It's like I'm not too concerned about the tricuspid regurg. And often it has to do how, how loose the lead is and things like that. Again, yes, it exists, not very common.
Thank you so much. That was a really, really good study. What fascinated me the most was the reduction in diastolic film pressures. In terms of day-to-day practice and going forward, I know we're still on the process of getting a multi-center study.
Yeah.
How do you see it rolling out to day-to-day practice?
Yeah.
That's a very fascinating numbers in diastolic.
Yeah, I can tell you how I practice. So I try to avoid beta blockers in all HFpEF patients. Because half of them will have either paroxysms of atrial fibrillation or permanent atrial fibrillation, anything in between. I tend to give them DILT. Again, DILT has been shown to be superior to beta blockers in hypertension outcomes trials. So I like DILT a lot. With the RADE-AF trial, I sometimes reach out to digoxin now again too, which I induced digoxin in a long time. Now we have a European trial that used digitoxin, which is liver metabolized, that showed that there may be efficacy in heart failure reduced ejection fraction too. But it's like I go DILT first and then DIG, but I really try to get rid of the beta blocker. Can I just say one more thing? You may say, hey, why is DILT better than beta blockers? And DILT does not induce the same symptoms as beta blockers do. And DILT has use dependence, meaning it tends to bind to the open channel more. So it works much better at higher rates, whereas the normal resting heart rates are little affected by DILT. And that's a real advantage because beta blockers, if this is your exercise heart rate and this is your resting heart rate, beta blockers push both down, and DILT does basically this.
So what you just said about diltiazem is somewhat a problem clinically because DOACs are used for anticoagulation. And there's increased bleeding if you use diltiazem. The other thing is the AFFIRM trial actually showed that DIG and beta blockers were the most effective way to control heart rate. Now, they didn't randomize to treatment, but still it was the largest population that looked at that. So I'm not sure where your data is coming from that you said DILT is better.
It's still, there is no comparison. There was never a comparator trial in atrial fibrillation between DILT and beta blockers. However, there are small randomized trials out of Norway that compared secondary outcomes, including NT-proBNP, and DILT was clearly better on NT-proBNP. So if you accept NT-proBNP as a valid outcome, I would argue that the randomized evidence is leaning towards diltiazem.
But you make a good point. Obviously, if you have atrial fibrillation and hypertension, you might expect that if you lowered the blood pressure more because you picked diltiazem, that you would actually have a salutary effect. So I wouldn't disagree with that. I'm just trying to point out some of the clinical things.
No, you are absolutely right, and I like when people push back. But I can give you another example. At ESC, or actually it was not ESC, the ABYSS trial, this was coronary artery disease and beta blockers, and it was randomized to beta blockers or like nothing, basically. And what they saw, and there was like the clinical outcomes, the heart clinical outcomes, and mortality was the same over a couple of years. But what they saw is beta blockers reduced blood pressure by 3 millimeters of mercury, but that reduction in blood pressure did not result in an improvement in outcomes, and it should. Because of all the outcomes that we modify, blood pressure is the one that's the biggest drivers of benefit.
One other observation is we've known for a long time clinically that if you have somebody with atrial fibrillation, you're setting up their heart rate. But it's amazing how it's very difficult to get people to want to program their device with a low rate of 70 or 75. Yet historically, we know that they have less atrial fibrillation if you do that.
Yeah.
But I think the concern has always been the prevalence of ischemic heart disease, where you'll actually get patients with more angina if you turn the pacing rate up.
Yeah.
Although I would submit pacing is a poor way to create myocardial ischemia, and I know that because we did some studies years ago about looking at that. But a lot of what you're saying, though, is very apropos to this audience, and I think the point is we should always be challenging ourselves to be looking at things perhaps in a different way.
Yeah.
And along those lines, Chuck, I want to, in a sense, challenge and ask you, should we have a different process for setting our lower rate on, default pacemaker implants? 60 does tend to be the default.
I'm gonna answer this question. Give me 30 seconds. The way the device companies have set this up, it's like having your children at home. They come and they turn all the lights on in your house. And you're frustrated because all the lights are on. And you say, well, why do we have to have all the lights on? Well, the way they come out of the box is how oftentimes they're left with all the lights on. So there isn't necessarily a lot of thought that goes into that, other than anachronistic doctors like myself, but that's just the way it is.
And it's like, most cardiologists are still buying in the low is better. I was like, Medtronic has me fly around the country right now, and I sometimes talk to practitioners, and they go like, what, really? 60 is not great for everybody. And I say, no, it's not great for everybody. It's like, and it's really how they come out of the box. And it was actually Earl Back, and they made that decision based on really not science.
Well, it's probably battery life too.
Absolutely, yeah. And then the one thing is, if you have bad leads, let's say you have a patient who has, depends on his RV lead, is more than 20% RV paced, and has an RV apex lead, don't pace them faster. Because it will eat into the benefits of heart rates by inducing dysynchrony. And we do it in full comprehensive physiologic pacing patients. And in them, I feel confident that this will convey a benefit. But with legacy systems, I'm a little worried.
There are some patients that I get to see that have heart rates in the 40s and 50s and actually develop LV dilatation, but they're asymptomatic.
Yeah.
And some of my colleagues would say, well, you shouldn't put a pacemaker in an asymptomatic individual. But I would argue that if you're dilating your left ventricle and looking forward to mitral insufficiency, you really should pace, and you should pace sooner.
And the risk for atrial fibrillation. That's
And
the
risk for atrial
that's the
fibrillation.
most common reason why these patients are seen, because they develop AFib.
So thank you very much.
Yes, thank you, Dr. Meyer, for your time this morning. Really appreciate it. We do have one webinar question thus far. It comes from Dr. Edwin Zashiri. He says, fantastic talk. And his question is, can you also comment about the role of cardiac contractility modulation pacing beyond just heart rate elevation in HFpEF patients?
Yeah, so this is completely my opinion, but I'm a calcium handler by scientific background. I can tell you what they do will locally, where the lead is, will have the effects that they say it should have. But, without having that stimulus being able to travel to the lateral wall, I don't know how that benefit should be conveyed to the lateral wall. It's a small regional effect that I cannot see going through the rest of the myocardium. So the problem is they did a couple of studies, and it was basically implant of the device, but we know that device implants have a huge placebo effect. So we are probably mostly looking at placebo effect. But they have now a randomized trial, that's my understanding. In Elevate, we have a sham. We have like a device implant in the control group that is set on VBI 30. So that's a true comparator. If you just run these trials and you don't have a decent control, you'll get positive effects from any intervention, and specifically device implants. That's huge for patients. Maybe one last word, if this works, there are not enough EPs in this country. Medtronic would say market size, but the number of patients affected by this is enormous. Worldwide, there have been 400,000 TAVR implants just in a year. If this works, 1 million US people could qualify for this. So you just need to hire a lot more EPs. Just kidding. Yeah. Thank you for having me.
Thank you.
And again, if you have patients, let me know, call me.